Okay. So last time we talked about this funny relationship between water and salt. And essentially, it comes down to this, that when the sodium level in the blood gets too high, the body doesn't address that by changing anything about sodium. Instead, a sodium level that's too high the body treats it as a water deficit. So what it does is it adds water, in other words, it makes you thirsty, having that happen. And then we also reduce our water losses. So the kidney holds on to water. You're thirsty, so you add water. Those things together help to add water to the blood, which dilutes that sodium and raises that sodium level, or lowers it rather, back to its baseline. So we address a too high sodium with more water. And the opposite is also true. If the sodium concentration in the blood gets too low, it's considered or dealt with by the body as a water excess. So antidiuretic hormone is blocked, aldosterone is blocked, and that causes huge amounts of water to enter, to be made into urine. And it also decreases thirst, so you don't add water on top of it. So it's the relationship between sodium and water. And where we stopped last time is looking at basically the four different cases of that. All right, so in the case of the rising sodium concentration, that's that first line over there. So, what happens? Well, we go from homeostasis to an increased sodium level. Well, how? Taking in excess sodium can do this. If you have a very salty snack, for example, or you misread or miscalculate on a recipe. So your sodium concentration goes up, and the response to that is to reduce water loss and add water in. So ADH is released. ADH blocks water loss at the kidney, or at least reduces it. Aldosterone does that as well, although that isn't in our list here. And then ADH also makes you thirsty. So the two things, you'll add water, reduce those losses. And then while that's happening, the water is shifted out of the intracellular fluid space and into the plasma volume, into the extracellular fluid. We talked last time about how the ECF and ICF are in different spaces, but they're connected. They can, water can always move between them. And this is an example of that. Water will shift out to fix this sodium problem until these things can take effect. And then eventually, adding in that extra water is going to reduce that sodium concentration and get back to normal. All right, so treated sodium level that's too high is treated by the body as a water deficit. All right. And then the opposite is also true. Okay, so here's normal. We have a decline in sodium. Well, how could that happen? Drinking a big glass of pure water can do this. It'll transiently reduce your sodium concentration because you've added water to it. Water is very easily and rapidly absorbed from the digestive tract, so you can get that kind of thing. And the response to it is the body treats it like it's a water excess, because usually that's what it is. So when you get a drop by 2%, ADH secretion stops, thirst is suppressed, and then water is lost in the urine, and eventually you get back to homeostasis. Because if we have a sodium concentration that's too low, and we take water away from that solution, it's going to go back up to normal. All right, and then I just have a little reminder here that antidiuretic hormone can affect water separately from sodium. It's the only hormone that can do that. The other major player in fluid retention is aldosterone, but aldosterone works with water and salt together, as we'll see a little bit later on. So it's just important to note that ADH is the water hormone. Aldosterone is the water and salt and potassium hormone. All right. So in that first case, okay, when sodium is too high, if the body treats that as a water excess, well, what happens if you have a lot of salt in your diet? The more salt you eat, the more water you'll drink, right? So doesn't that mean that you'll just end up with more and more fluid in your body? No. There is sort of an alternative path that prevents that from happening. Because if we just had that top line there, sodium is too high, drink more, we would just, if we had too much salt in our diet, we would just get more and more water. We'd have more and more fluid in us, which doesn't make sense. So there's an off switch for that, and that is this system right here. Okay, so the more water or the more salt you have, the more water you drink. The more water you drink, the higher your plasma volume, right? The higher your plasma volume, the fuller the heart is before it begins to contract. Remember, end diastolic volume, as big as the heart gets. Well, when you get to have too much blood circulating, the heart gets too full at the beginning, and we get what's called atrial distension. So the atria are stretched by this excess fluid volume, and their response to that is they release hormones called natriuretic peptides. Now, natrium is sodium's fancy name. So if you look at the periodic table, I think it's number 11, third column down is Na. Well, we call sodium Na because its proper name is natrium. So that means that these peptides affect sodium. Natriuretic, right, sodium, and etic, or uretic, is to urinate or release in the urine. So natriuretic peptides do what their name says, and that is they cause the release of sodium, or the urination of sodium. Like diuresis is urination or causes urination. All right. So the natriuretic peptides, that's principally what they do. They cause an increase in sodium loss in the urine. Well, water always follows salt. So if we're going to increase the amount of sodium in the urine, we're going to increase the amount of water in the urine automatically, right? These peptides also reduce thirst, and then they inhibit the hormones that hold on to water. So they inhibit ADH, they inhibit aldosterone, and then they also inhibit epinephrine and norepinephrine. That helps to reduce the blood pressure. So these natriuretic peptides are important, even though we don't hear much about them, because they make sure that the plasma volume never gets too large. We want to have an answer for too low and an answer for too high. So the answer for too high is these natriuretic peptides and loss of water in the urine. All right, so as sodium and water are lost, that reduces the blood volume, reduces the blood pressure, and then eventually we get back to normal, right, where the atria are not being distended anymore. So, the classic example here is, you're eating a salty snack and you're drinking water. Eventually, your plasma volume is going to get too high. So, what happens next? Urination is triggered. Make urine, get rid of that extra water and salt so you can get back down to normal. All right. So that's the case of the fluid volume being too high. Well, what about the fluid volume being too low? This is one that we've looked at now multiple times. So we started looking at it in the, I believe, in the endocrine chapter. But this is the renin-angiotensin-aldosterone system. Okay. So whenever the blood volume gets too low, it causes a decrease in blood pressure, right? Not enough blood circulating is there's nothing to make pressure in. So, here's our example of we have normal and then we fall off from that. So our extracellular fluid volume decreases for whatever reason. So we get a decrease in blood pressure and blood volume. That is identified at the kidney, principally, because remember the kidney works using blood pressure to cause filtration at the glomerulus, right? So if the blood pressure falls off, the kidney is the first to notice, so to speak, because the glomerular filtration rate falls. The response to that is to release renin. Renin brings about angiotensin 1. Angiotensin 2 is created in the lungs by the ACE enzyme, the ACE enzyme. And then angiotensin 2 does all kinds of things, one of which is to increase blood pressure by increasing total peripheral resistance. Another is to trigger the release of aldosterone and ADH. So when the plasma volume is too low, blood pressure is too low, and the result is to hold on to as much water as possible. In addition, we increase thirst when this renin and angiotensin 2 and ADH make you thirsty. which increases your water intake. So we have a combined effect, all of which have the same idea, which is to reduce water loss and increase water intake. And as long as the patient is conscious and able to do those things, eventually that extracellular fluid volume is going to come back up to normal, and then that system will stop because renin levels will then go back down. So you might want to just mark on this slide, this is the renin-angiotensin-aldosterone system. Because this diagram is simplified compared to how we've looked at this in the past. So in the cardiovascular system and then in the renal system, we looked at this in more detail. But no point in going through all of that again. All right, so here this is the too little total body water or too little total body sodium or both. Because either of those can cause this same problem. So, let's say that you had been on an ultra-low salt diet, because you heard that salt was bad for you. Eventually, you will get into this case where your plasma volume will be too low, not because you aren't drinking enough, but because you don't have enough salt in you to hold the water inside. It'll just sort of pass right through. So we do need some sodium in our diet to prevent that from happening. Now, in humans, that hasn't occurred in thousands of years, because humans have been mining salt for a long, long time now. But in animals who live in a very salt-poor environment, it's one of the ways they can die is from a salt deficit. And what happens is they essentially die of hypotension, of too low of blood pressure. So don't be afraid of salt, but too much salt is kind of bad for us. Okay, so let's do a question here. When pure water is consumed, what happens? And hopefully we'll have better luck with integrity today than yesterday. The question coming through?
Yeah.
Good. I just forgot this one's a little harder than I thought. All right, so the best answer there is A, the osmolarity of the two compartments fall. Okay, so let's talk about that. All right, so we have intracellular fluid and extracellular fluid, right? And in both, you've got all this stuff dissolved in it, right? And we learned that water can shift between these compartments. Well, in this case of pure water consumption, so when you drink the water, where does it go first? Well, it's going to go to the extracellular fluid space first. So to use our diagram, we've taken this volume of stuff and we've added pure water. So you notice that the water doesn't have anything dissolved in it, right? Because it's pure. So what happens? Well, the first thing is this water isn't going to stay in the intracellular space or extracellular space. It's going to equilibrate across. So in the end, we'll get this. So the whole volume of both will have gone up because the water doesn't stay where you put it. It moves around. But if we take a fixed amount of water and solute and we add pure water to the whole thing, the osmolarity is going to go down, right? Because we've added water, we've diluted it. So the answer there is A. Both compartments' osmolarity will fall. Okay. Because when you add water, the volume of the extracellular fluid space is going to go up. Eventually, the volume of the intracellular fluid space is also going to go up. And a fluid shift occurs, yes, but it causes an increase in the intracellular fluid. And adding water makes things more hypotonic. So just to sort of go through the answers. All right, I like this question. Consuming a meal high in salt will do which of those things? I always forget about this. Consuming a meal high in salt when you can drink as much as you want to. Okay, you have access to water, or the patient has access to water. The best answer there is C. So anytime you add salt to your system, what happens next? Well, you get thirsty, right? Because you have to offset that salt. So when you've had a high salt meal, your blood volume really is higher than it usually is. It's a direct effect. So you wouldn't think that something as simple as doing something that we do on a regular basis could have a physiologic effect, but the bottom line is it does. So until that salt that you've taken in ends up in the urine, you have a transient increase in blood volume and hypertension. So there again, after going to the movies and having a bunch of popcorn and drinking a bunch of soda, your blood pressure is probably up because your plasma volume is up. All right. So that was sodium balance and water balance. The other ion that we pay particular attention to is potassium. And potassium is a little different than sodium because potassium is principally found inside of cells, right? So here's our cell. The outside environment is very high in sodium. The inside environment is very low in sodium and very high in potassium. So it's a sort of root difference between the inside and outside. And for those of you that had me last semester, we talked about this when we talked about the action potential and membrane potential, right? The sodium and potassium difference. And remember, there's a pump here on the membrane that pumps potassium in and sodium out to maintain this difference. So why does that matter? Well, it matters because when we measure the plasma potassium, in other words, we take blood from the patient, we spin it to remove the red cells and white cells, and what's left is the fluid part of blood. The potassium level of that space is actually very low, about 5 milliequivalents per liter, even though inside the cells it's much, much higher. So the plasma potassium, which the normal range is right around 5, doesn't tell you very much about the whole body. It just tells you about the plasma. So where does potassium come from? Well, it comes in from our diet, right? So here's absorption. And it doesn't, once it's absorbed, it's pumped into cells. So when we sample the plasma, we only get a very small amount. And essentially what we're seeing there is the potassium that leaks back out. So the sodium-potassium pump pumps potassium in, but potassium is leaking out all the time. That's this dotted arrow. And that is what establishes that normal potassium level of 5. And then eventually, what goes in has to come out somehow, right? So the kidney is responsible for getting rid of excess potassium, which it has to do all the time because in our typical diet, there's quite a bit of potassium. So the amount of potassium coming in from the digestive tract in a day has to equal the amount of potassium excreted by the kidney in a day. So it has to sort of be in balance. All right. And I don't hear the 98% of the body's potassium is inside of the cells. So it's very difficult to assess how much total potassium a patient has. So a potassium deficit, from a dietary deficiency, can be hard to identify because you can't sample all the intracellular fluid. You can only sample the extracellular fluid. But thankfully, that doesn't come up very often. All right. So just like sodium, potassium concentrations have to be regulated. And they're regulated by our friend aldosterone, which we learned about a little in the last chapter. So aldosterone is a hormone produced by the adrenal gland. And its primary function is to control the presence or absence of these sodium-potassium pumps that are found in the distal convoluted tubule and the collecting duct in the nephron. So, why does that matter? Well, these aldosterone pumps serve two functions. One is to retain sodium, and the other is to dump potassium. So aldosterone does two different things. So it causes NaCl retention. We see this effect when blood pressure is too low or when plasma volume is too low. So if you're dehydrated, for example, your blood pressure will be down. That'll cause aldosterone to be released by that angiotensin-aldosterone system. That aldosterone will trigger these pumps in this area of the nephron to pump sodium in. You see how the sodium is being pumped towards this is the blood over here, this is what will become urine. So we have sodium retention when blood pressure is too low. So we'll say this is a decrease in plasma volume or a decrease in blood pressure. But then aldosterone has another path too, and this is when potassium is too high. Aldosterone is released, and aldosterone causes potassium secretion. Right? So just like the sodium is moving into the body, here's the potassium being pushed out. So aldosterone serves double duty, and these pumps do too. They can either be used to retain sodium or they can be used to secrete potassium. Now, they are also not separable. This pump can't work by just secreting potassium. So, if I gave you a bunch of potassium and aldosterone would be released to get rid of that potassium, but a side effect of that would be sodium retention. So I would elevate your blood pressure and your plasma volume by giving you potassium, because giving you potassium causes you to retain sodium. Because in order to get rid of the K, we have to hold on to the Na. So it's a connected thing there. It's one of the reasons why, in a patient with high blood pressure, you try to restrict the potassium in their diet, because the more potassium they have, the more sodium they'll hold on to. So there's sort of a give and take here. About that. All right. Okay. All right. And there's yet another caveat to the use of those pumps, and that is the relationship between acidosis and hyperkalemia. So just like sodium is natrium, potassium is kalium. Yeah, kalium. Okay, so here's the normal case. So if the potassium level is too high, aldosterone is released, right? We get potassium being secreted, sodium being retained. Well, when the patient, or when the pH of the body is too low, in other words, when you have an acidosis, an excess of hydrogen ions around, we get a different effect. In a sense, if the pH is too low, the H plus concentration is too high, that's a problem, right? The body only works right in a very narrow pH range, which we're going to talk about here in a minute. So at the kidney has a choice, so to speak. If it can get rid of potassium or it can get rid of hydrogen ion, because this is the same pump. It can do either thing. And what happens is the hydrogen ion takes priority. So all of this relationship it's easier to summarize it like this: as A plus concentrations go up in the body, that tends to increase potassium concentrations in the body. And here's why: because when the hydrogen concentrations are high, the kidney, instead of excreting potassium, it will excrete hydrogen ions instead. So that means every time that this occurs, this doesn't, because there's only so many of these pumps present. So it means that whenever you have a patient with acidosis, they usually develop hyperkalemia too, because the principal system for getting rid of potassium is sort of hijacked by the kidney trying to get rid of the acid instead. So it's just a very common thing you see in patients. All right. Okay, so potassium, like I said, most of it is locked up inside the cells where you can't see it in the lab. But it is one of the most common clinical electrolyte disturbances, is potassium disorders. And the bottom line is both directions are a problem. A potassium level that's too low can kill you, and a potassium level that's too high can kill you. Just like with sodium, too low or too high are both bad for you. So the normal range is 3.5 to 5.5. That's in the plasma. So you take your blood from the patient, take the red cells out. The lab measures how much potassium per liter is present there. Okay. So we see both, and both are important. Both hyperkalemia and hypokalemia. Too much or too little. And whenever you think potassium problems, think EKG, because for both too low and too high, the heart is of the principal concern, because hyper or hypo can cause arrhythmias, can cause the heart to stop. So that's what makes it so clinically relevant, is that. So what causes hypokalemia? Too much aldosterone can do that. There's a disorder called aldosteronism or hyperaldosteronism that does that. Too much aldosterone means too much potassium secretion, right? So the potassium level falls. Probably the most common cause for a potassium level that's too low is iatrogenic. In other words, hospital caused or medicine caused. And that's because our most powerful diuretics, medicines we give to increase urine output, are because of how they work, they result in an increase in potassium in the urine. So if you take an increase of urine output together with an increase in potassium in the urine, you're peeing out more potassium than you're taking in. So your potassium level falls. The most common culprit there it's called Lasix, furosemide. It's a very powerful diuretic. You can inject it, and then the urine output begins minutes later. So it's very effective, but the downside is it's potassium wasting. So the patient becomes hypokalemic if you're not paying attention. So typically a patient who's on Lasix is also on a potassium supplement of some kind to prevent that from happening. Hyperkalemia, the most common cause is either a mistake in IV fluids, which doesn't happen very much anymore, but too much potassium in the IV fluids will do this, and it's associated with kidney failure. So one of the things that the kidney is doing for us all the time, we talked about uremia, how when your kidneys fail, your toxin levels go up. Well, potassium, there's a lot of potassium in our diet, and it's up to the kidney to get rid of it. There's no other place in the body that potassium is shed. So when your kidneys don't work right, your potassium level has a tendency to go up. So one of the reasons that kidney failure patients need dialysis as often as they do is sometimes because to get the potassium out of them. And typically, a patient in renal failure is on a very low potassium diet as well because of that. All right. And just a little sort of clinical point of importance. Potassium levels, in the hospital environment in particular, and I suppose in the clinic as well. In the modern day, we use blood labs to make all kinds of assessments about patients, right? And when you send a sample to the lab, it is very easy for them to run all kinds of tests on that one sample. So what we have a tendency to do is we order panels of labs, right? Lists of, one blood sample, 10 tests, right? Well, on many of those panels, potassium levels are checked for. And, maybe reasonably so, because we want to see that potassium levels are normal. The problem is, in potassium measurement, we have this conflict. So most of the body's potassium is inside of cells, right? When you draw blood from a patient, you're drawing plasma and blood cells, both. What you want to know is you want to know what the potassium level in the plasma is. But along with that plasma, you've gotten a bunch of red cells, all of which have a ton of potassium inside of them. So the long and short here is, anytime blood cells break open during the process of getting the blood out of the patient, that's going to falsely elevate your plasma potassium level. Because what you've done is, you've taken plasma, but then you've added a bunch of potassium to it that used to be inside of red cells. So all that to say, the vast majority of high potassium labs are not true. They're false because of this issue of, we call it hemolysis. When you break open a cell, a blood cell, it's called hemolysis. And when you have, particularly if you have a difficult time getting blood out of a patient, you're going to have destroyed a bunch of red cells in that process. So you're going to send your lab off, and the results are going to come back, and the potassium is going to be 8 or whatever. And is the potassium in the patient really 8? No, it's not. Potassium in the blood sample you sent was, but it's because you broke up with a bunch of red cells. So just be careful. Don't panic when you see a high potassium level. There is another reason why that can happen, and that's this effect of hemolysis.
So is that why they'll take the blood labs at like 5 in the morning, and then they'll take another one at like 11, and then they'll take another one at 4?
No, they usually do that if they're following something.
Okay.
And it is true that running a panel of labs, a list, is actually cheaper than running them one at a time. But no, the reason they're doing that is they're looking for an incremental change over time. Yeah. Good question, though. And it's, as you guys get out into your clinical training, pay attention to the lab stuff, because more and more decisions about patients are made looking at the laboratory. So if you want to know what's going on with the decision making, you have to keep track of the labs as well as everything else. All right, let's do a couple more questions. All right, so aldosterone. What does aldosterone do? Did it come through? Yes. Did for anybody? Did it come through for anybody?
I got it.
Some of you got it, some of you didn't. I don't know what's going on with that thing.
Like ever since they redid it.
I don't know, but she never messed with it. Yeah, I only got like 2 answers. Okay, so let's look at these. Aldosterone promotes sodium retention in the kidneys. Yes, because it pumps sodium back into the blood. B is secreted in response to elevated levels of potassium. Yes, that's that bottom branch of our diagram over there. And helps decrease blood volume and lower blood pressure. No, it's just the opposite. Aldosterone helps to increase blood volume and blood pressure. So the answer is there, E, A and B. All right. Okay, so the last topic in this chapter is the longest one. So we're going to start it now, and then we'll finish it up next time. And that is the concept of acid-base balance. All right, so here are the players in that balance. Okay, so the cells of the body make acid. It's just that's the way metabolism works. So they make carbon dioxide and they make acid. So they make H pluses, compounds that release hydrogen ions. And the CO2, when it dissolves in plasma, when it does that, it creates a hydrogen ion as well. Remember we talked about that the equation H plus HCO3 minus, we get H2CO3 and CO2 plus water. So when we're going this way, CO2 that's also made by the cells ends up producing a hydrogen ion as well. All right, so here's the maker of the acid. Then we have two excretors. The lungs release CO2, and that drives this reaction this way. So as we blow off CO2, we also get rid of a hydrogen ion, right? Because we stick it to water, and then it's no longer acidic. And then the kidney, it can excrete H pluses directly, which is needed because not all acids, as we'll see in a minute, can be affected by this equation. So we have the lungs getting rid of hydrogen ion, and we have the kidney. And then we have the buffer systems. So in chemistry, do you all talk about buffers?
Yes.
Have you talked about buffers? Anybody never heard the word buffer before?
Yes, we talk about it.
Okay, good. Because it's hard to describe at different levels. But anyway, a buffer system is a set of molecules that can essentially hide or hold on to a hydrogen ion and keep it from affecting pH. Because the normal pH of the plasma is 7.35 to 7.45. That's a very narrow range, right? That's 0.1 difference around 7.4. And we need to have that be normal, even as we add hydrogen ions and take hydrogen ions away. So the buffer systems allow that to happen. The pH stays the same even as hydrogen ions are added or taken away because of how buffers work. And we'll look at a couple of different examples of buffers as we go on here. All right. So in the body, there are three classes of acids: fixed acids, organic acids, and volatile acids. Okay, so we're going to do this last one first. This is the volatile acid right here. So carbonic acid, which is this piece, is what we call volatile because under the right conditions, it will gas. You know, a thing that's volatile can become a gas very easily. So carbonic acid becomes CO2 plus water. And then the CO2 then can be breathed off. So that's a volatile acid. The fixed acids are acids that once they're produced, they don't go anywhere and they don't change. So an example of this is like the fatty acids or the amino acids. So the only way to get rid of fixed acids is the kidney has to excrete the molecule that produced it. Okay, so the fixed acids have to be removed by the kidneys. There's not another way. So sulfuric acid, phosphoric acid, hydrochloric acid are all fixed acids. Okay, and then the third group is the organic acids. And these are acids that typically can be metabolized or broken down into something else. So the best example of this is lactic acid. When we use our muscles in an anaerobic way, lactic acid builds up, right? That lactic acid, we're not stuck with it. We can take lactic acid, and when there's oxygen present, we can break it down into CO2 and water. So the organic acids can usually be metabolized into something else, but they can be removed by the kidneys directly if there's a metabolism problem, right? So fixed acids, the kidney has to get rid of. Volatile acids, the lungs get rid of. And organic acids are usually intermediaries in metabolism. In other words, they're not finished yet. They haven't been fully processed. Or they'll end up one of these in the end. All right. So we'll do this one and then we'll call it a day. Okay, so here's pH. It's a little non-intuitive because it's logarithmic, which means that, you know, we go from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, right? So from 0 to 14. But what isn't clear is 8 is, or 6 is 10 times bigger than 7. 5 is 10 times bigger than 6. So this scale, even though it's small, represents a huge spectrum of chemical environment, right? So, you know, so if you drop the pH from 7 to 6, you increase the number of hydrogen ions by a factor of 10. So you're talking big numbers. The human body is just slightly alkaline, so slightly basic. So 7.4, and this is a number you should know for sure. 7.4 plus or minus 0.05, right? That's normal pH. And a departure from that of even 0.2, you know, so a patient, if you get a lab and the patient's pH is 7.2, that's a critical value. So it's that much of a, you know, there's not much room for difference. And it's because the proteins in our cells that make our cells work are very pH dependent. Because if you change the pH around a protein, the protein changes shape. And as we've seen, you know, in a couple of different places, protein shape is really what makes proteins work. So we have this very narrow range and we defend it very vigorously. All right, and we're going to stop there and we'll finish up acid-base next time because we're almost out of time, but I don't want to start a new topic. All right.